To get started, I want to welcome you to the OBSSR Director's webinar for March titled From Patient Perspectives to Preventive Care, Harnessing Technology to Improve Adult Pneumococcal Vaccination. I'm Christine Hunter, the Deputy Director of the Office of Behavioral and Social Sciences Research at the National Institutes of Health. And before I introduce today's speaker, I'd like to mention a few housekeeping items. First, today's webinar is being recorded, so a recording of the webinar will be available on the OBSSR website in about a month. Today's presentation will also be followed by a Q&A session. All the phone lines will be muted during the webinar, so questions and comments will not be taken via phone, but you can submit them via the Q&A feature on WebEx. To ask a question or send us a comment, just click on Q&A on your screen, select Ask All Panelists, and type in your question and hit Send. My colleague, Dr. Bill Elwood, will facilitate the Q&A session by reading the questions you send aloud to the speaker. Feel free to send a question at any time during the webinar, and the question will be asked following the presentation. Today's speaker is Dr. Kenzie Cameron. Dr. Cameron is a communication-trained health services researcher with expertise in theory-based message design, persuasion research, and innovative interventions promoting behavior change. Her work has informed clinical patient care by identifying and addressing key information needs of diverse populations, information which then serves as a foundation for the development of theoretically based targeted messages. Dr. Cameron uses mixed methodologies to increase individuals' use of preventive services, including adult vaccinations and cancer screening, with a focus on addressing racial and ethnic disparities. She's passionate about mentoring and has successfully mentored multiple faculty to career development awards, NIHR awards, and AHRQ grants. In 2016, she was named a Fellow of the Academy on Communication in Healthcare in recognition of her significant service and scholarship in the field of healthcare communication, and she was awarded the Feinberg School of Medicine Mentor of the Year Award. So without further ado, I'll turn it over to you, Dr. Cameron.
Great. Thank you so much, Dr. Hunter. And I want to also thank Dr. Bill Elwood and Erica Moore, who's behind the scenes, as well as NIH and OBSSR to have this opportunity to speak today. So as mentioned, I'm going to take everyone who's on the webinar today through kind of a multi-year, multi-stage project that was focused on improving adult pneumococcal vaccination. And this was a project that was funded by AHRQ. I have no specific disclosures to report. And I know on the first screen you saw a nice view of the lake in Chicago where I am, although it doesn't look that pretty today. It's a little gray. But I know there are some of you out there who I've met before, are colleagues of mine, and many who probably I have not yet had the chance to meet. So I wanted to let you see who it is that's talking to you today. So as Dr. Hunter mentioned, I'm Kenzie Cameron, and I'm in General Internal Medicine and Geriatrics here at Northwestern Feinberg School of Medicine. I have a little note on here that all of the studies that I'm talking about today were indeed approved by the IRB. Since I'm talking about kind of many studies under one project, I'm just not going to continue to repeat, and it was approved, but everything was IRB approved. Before I start, I want to recognize some members of the team. Of course, nothing ever happens alone. This doesn't even include the entire team. I couldn't get pictures of everyone, but here on the screen you see a number of individuals, and at the end I'll provide names as well that we could not have done this project without, and I want to recognize them as well. So to give you a sense of where I'm going and how I'm going to get there today, I'm going to do a quick overview of pneumonia and pneumococcal vaccination, and then I'm going to dive into where we really started with the project, which was attempting to understand Black patients' refusal of pneumococcal vaccination, and I'll explain how we got to that question itself. I'll talk about a video that we developed and give you a chance to see it. I'll talk about how we then used that video by delivering it through the electronic health record at the point of care, so within the clinic, and then later on delivering it through a patient portal of the electronic health record. So to start at the beginning, thinking of pneumonia and pneumococcal vaccination, the disease, the vaccination, as well as the disparities that we see in vaccination. Pneumonia itself, so Streptococcus pneumoniae, also referred to as pneumococcus, is and remains one of the leading causes of vaccine-preventable illness and death in the United States and indeed around the world. We know that older adults tend to bear the significant burden of disease. They are more likely to get pneumonia and they are more likely to die from pneumonia. So the Advisory Committee on Immunization Practices recommends vaccines for adults 65 and older. There are now 2 vaccines that are recommended, and I'll talk a bit about the fact that there are 2 vaccines a little later in the program. When we look at where we are and where we stand in terms of pneumococcal vaccination in the United States, we've made great strides. So this chart shows you that within 2 decades, we went from just over 40% of the adult population 65 and older being vaccinated to 69.1%. So certainly we have seen great increases in vaccination. However, Healthy People 2020's goal is 90% vaccination of all adults 65 and older. So although we've seen great increases, we still have a ways to go to get to that 90%. Also, what you see here in front of you is the overall percentage of adults vaccinated, 65 and older, so 69.1%, but then you also see that there remains a disparity in pneumococcal vaccination among non-Hispanic whites and non-Hispanic blacks. And that is a disparity that has continued for years. It has not always been explained by access, and so a number of us have been looking to say, well, what else might be causing the disparity? What other issues can we look to address? That's what led my team and I to this first question. And I'm going to unpack for you why we flipped to refusal of vaccination as opposed to receipt and acceptance of vaccination. I'm jumping a few years back here from the previous slide because we started this program back in about 2012. But as you can see, it looks the same. We still have the disparity between non-Hispanic whites and non-Hispanic blacks receiving the vaccine. Of interest, a number of individuals that I work with, my colleagues here at Northwestern, had done a fairly significant quality improvement study. And in 2009, they were able to actually reach almost 90% of our adult population 65 and older. So 89% of the patients had received the pneumococcal vaccination, but as you can see, there remains a disparity between the non-Hispanic black and the non-Hispanic white patients. What was particularly interesting in this research, led by Dr. David Baker, Dr. Stephen Purcell, and Dr. Muriel Jean-Jacques, is they were able to look not just at receipt of vaccination, but at refusal of vaccination. So previous research had implemented an electronic health record quality improvement system, which allowed the physicians to document when the vaccine was given and also when patients refused a particular preventive service. And pneumococcal vaccination was one of those preventive services identified. Now, this refusal wasn't used if a patient said, I'm just not interested in it today. It was meant to be used when the patient was absolutely refusing that preventive service. And what you see here is well over 3 times as many non-Hispanic black patients had a documented refusal of the vaccine in our system, compared to only 3% of non-Hispanic white patients. So we wanted to say, can we learn more about why individuals might be refusing the vaccine? So our objective in the first part of this project was to try to unpack and understand some reasons for refusal of pneumococcal vaccination. For those of you who know me, you know that I am very tied to my underpinning of theory, and I come from a very theoretically based perspective. The theories that we were building this project on included those of consistency, so some of Hyder and Festinger's work, as well as the extended parallel process of WITI, a fear appeal model that looks at constructs such as perceived severity, perceived susceptibility, perceived self-efficacy, and perceived response efficacy. Our participants were all 65 years of age and older, Black patients who had a documented refusal of pneumococcal vaccination within our electronic health record. We did a telephone interview, and some of the measures we were looking at perceptions of susceptibility to pneumonia, perceptions of severity of pneumonia, beliefs about the side effects of vaccination, whether or not there were perceptions of normative influences relevant to vaccination, and then to get at the consistency aspect, we looked at comparative perceptions of perceptions related to childhood versus adult vaccines. So we uncovered a lot more information that I'm necessarily going to show you today, but in order to pull everything together for this presentation, I'm highlighting some of the key issues that took us to our next step. One of the things we did look at, we were able to look at for the 40 individuals that we interviewed, was history of preventive services. So all of the individuals we talked to had refused pneumococcal vaccination. What you can see is that a number of them don't appear to have other adult vaccinations, but that's not across the board. And there was a high receipt of cancer screenings and other preventive services. When we looked at responses to some of the questions that we asked, something that really stood out to us was when we looked at susceptibility and severity. So when we asked our participants their perception of their risk for getting pneumonia, it was fairly low. And you can see how different it was from their perception of the severity of pneumonia in knowing and believing that pneumonia can kill me. So that highlighted to us that it appeared as though there was a low perceived susceptibility, but a high perceived severity to pneumonia itself. Other interesting aspects that we learned from this initial research is when we looked at childhood versus adult vaccines. We asked participants to reflect on their perceptions of safety of childhood and adult vaccines. And what you see here is there was a significant difference in that our participants were much less likely to believe that adult vaccinations were safe. Similarly, when we looked at the perception of, well, how important is it that someone is vaccinated? Again, we saw a significant difference in that our participants perceived childhood vaccinations to be more important than adult booster vaccinations or vaccinations. So we felt that this perhaps could be a lack of consistency that we could work with. It wasn't necessarily a perception of vaccinations being unsafe or ineffective or unimportant, but that there seemed to be a change as we looked across the lifespan. So what we took from the first part of the study was, if we were to develop a message, we definitely want to increase perceived susceptibility, and we want to focus on this idea of consistency and the importance of vaccination across the lifespan, not just as a child. That then led us to the second step of our project, which was to develop a brief video that we wanted to show patients. Here you see a very brief overview of how we incorporated some of the constructs of the theories and the information we derived from our original interviews into the video. So we knew we had to focus on susceptibility. We talk about pneumococcus being everywhere. We knew that perhaps we didn't have to focus as much on severity, but we wanted to keep in this element of severity and that it can easily spread. Consistency, we wanted to bring in, again, this idea of vaccination across the lifespan and that vaccinations can be life-saving for both children and adults. We knew that narratives can be very effective in presenting information. And we also wanted to ensure that we addressed response efficacy, that the pneumococcal vaccination was something that could work and could save your life. So we created a video, and the first video we created, we took to focus groups to get their feedback. Our very first attempt, even though we knew that severity was already pretty high, apparently we still went a little too far with severity. Our focus groups told us it was a little too heavy on severity and fear. So one participant noted there was lots of talk about dying. I found it dire and uncomfortable. I was very uncomfortable watching it. So we knew we had to dial back on severity. The personal testimony did indeed resonate. An individual noted, I liked the man talking about his wife. He thought she died of pneumonia. She did all the right things. And when I show you the video in just a minute, you'll see how closely that resonates with what the video actually expressed. For those individuals in our focus group who were unvaccinated, most of them said they would at least discuss vaccination at their next visit with their physician. So these focus groups were made up of individuals who were 65 or 66 years old and had no documentation of receipt of vaccination or refusal. The reason we were focused on this 65 to 66-year-old segment of our population is we really wanted to be there at the beginning. We didn't necessarily want to be focused on individuals who perhaps have refused the vaccine for years. This project was to focus on those who were being initially told about the need for pneumococcal vaccine and get in there right at the beginning to give information to perhaps help shape their response to receiving the vaccine. Overall, the response to the video was positive, and participants liked the idea that we were going to show it in the clinic at the point of care. One gentleman noted, I thought it was an excellent production. It was short, and I think it would awaken a person's mind to the reality that the shot is good to have. And then finally, this issue of consistency across the lifespan seemed to resonate as well, with one woman noting, you're going through different life cycles. Once you become a senior citizen, there's things that you should be doing differently. I can see that correlation now. So we took all of this information and revised the video, reduced the severity that we originally had in it, and created approximately a 2-minute video that we would be able to show to patients. I'm going to step back for a second now and show you the final video that we created.
Are you afraid of pneumonia? You should be. Every year, pneumonia kills 7 times more people aged 65 and older than car accidents. Pneumonia is caused by bacteria called pneumococcus. Pneumococcus is everywhere. Pneumonia starts in your lungs, but can easily spread into your bloodstream and throughout your body. Pneumonia can make you very sick very fast, and it can kill you. Everyone is at risk of pneumonia, especially older people and young children. The good news is that the pneumococcal vaccine, also called the pneumonia shot, can protect you from dying from pneumonia. Just as you got vaccinated as a child to protect yourself, you need to receive important life-saving vaccinations as an adult.
My wife took good care of herself, making sure to wash her hands, stay away from sick people. She ate well, and she bundled up when she was in the cold. But she didn't take the pneumonia shot because she didn't feel she needed it. After all, she was doing everything right. When she got sick, she wasn't protected against pneumonia. I lost my wife 7 years ago. and I feel that pneumonia was one of the factors that led to her death.
Remember, vaccines aren't just for kids, and the pneumonia shot could save your life. Talk to your doctor today.
So now we had this 2-minute video, and we were ready to show it to patients. As I mentioned in the beginning, our focus was to incorporate this video directly at the point of care. So what we wanted to be able to do was individuals who were 65 and 66 years old, again with no documentation in their electronic health record of receipt or refusal of pneumococcal vaccine, when they came in for a visit and the nurse or the medical assistant roomed them, they would then show them this video before the physician came in. The idea was the video gave them some brief, important information about pneumonia that was general and important for everyone to know, and then the limited time they had with the physician could be focused on maybe a discussion of individual characteristics or individual concerns. That's also why the video was so short. You never know how much time there's going to be between when the nurse leaves the room and the physician comes in, but we thought 2 minutes might be okay, and in general it was. So how did we do this? We did this through a process within our electronic health record of what we call best practice alerts. And again, this came from my colleagues, Dr. Baker and Dr. Purcell's work, where they had implemented practice alerts that were directed toward physicians that would indicate if a preventive service was not indicated in the electronic health record. So this patient does not have receipt of pneumococcal vaccination. What does a best practice alert look like? It can look different ways depending how you design it. Ours ended up being this pop-up window, and as you can see, there's a yellow bar, there's a red flag, and it was to alert the nurse or medical assistant to play this video. Of note, this was the first time, certainly here in our system, that a best practice alert had been directed toward nurses and medical assistants. Up until this time, all of the best practice alerts had been directed specifically toward primary care providers. So we felt that this was an innovative way to make use of the time when we have the patient as a captive audience in the exam room, but then also we have the benefit of the clinic behind this message because they're seeing the video in a place where obviously it's endorsed and they can act on it right away. So our objective for this part of the study was to conduct a single-site feasibility test of a clinical decision support tool, so that was our best practice alert, that would prompt rooming nurses and medical assistants to show the video to patients who were newly eligible for pneumococcal vaccination. How did we make this happen? A team of programmers, clinicians, nurses, and communication experts created and tested and retested and retested the best practice alert. I want to point out that this is, 2 lines here on the slide, but of course it's a lot of work behind the scenes, which we could not have done without our information technology specialists and programmers. What would happen then is when the rooming nurse or MA opens the electronic health record, if that patient was 65 or 66 years old, there was no documentation in the system of receipt or refusal of pneumococcal vaccination, and there was no counter-indicating diagnosis suggesting pneumococcal vaccination should not be given, when the nurse opened the electronic health record, this box would pop up. Now, I'll talk a bit more about this later. Our initial hope was the box would pop up at the end. Because of some programming necessities, it had to happen at the very beginning. Because of that, we wanted to ensure that nurses had the autonomy to choose. So they could say, I intend to play the video, or this video is inappropriate. It's possible that the visit was an acute visit. We didn't want this to be in the way. That said, when we trained the nurses and MAs, our focus was on saying, use video inappropriate as seldom as you can. This is kind of a last resort. We want it there so you have the autonomy to choose, but as soon as you choose video inappropriate, that turns off the alert for the patient forever. So the next time the patient comes in, it's not going to pop up. So if you're not sure whether or not you're going to play the video, click intend to play video. And as you'll see, there were multiple other clicks they had to do, so they could choose at additional times to not actually follow through with the video. But we wanted to make sure we had this autonomy. If the nurse clicked, I intend to show the video then was shown to eligible patients, and it was immediately before the physician encounter. So the idea was the nurse or the MA would start the video, leave the room, so the focus for the patient would be on the screen without discussion getting in the way, and it would happen immediately prior to the physician coming in. If the physician were to come in less than 2 minutes, there was a way for them to stop the video if needed. What we found is a lot of times when the physicians came in, if it was still playing, they usually just let it play because they also knew it was only 2 minutes long. So we went to implement this and go ahead and get it started and have it go live in the electronic health record. Here you can see more of the team. And as we're talking through, what is it we should do? So here we go, we're implementing it. Things are going to go great. I'm going to take a minute to walk through what happened. So in the time frame that we had this alert live and running, 663 times the best practice alert fired. So the nurse opened the electronic health record for that patient and got this alert. Almost a third of the time, nurses selected video inappropriate. Remember that this was something we really wanted to be a last resort. So, that wasn't what we were hoping for. The good news, though, was over 2/3 of the time, nurses said, yes, I intend to play the video. But what you'll see is that in the end, less than a third of patients actually saw the video during that visit. The good news is the patients who saw the video were significantly more likely to receive pneumococcal vaccination than those who didn't watch the video. We didn't see any difference between our non-Hispanic Black and our non-Hispanic white patients in terms of receipt of vaccination. So it appears as though the video may have had some effect for those patients who saw it. We asked nurses, MAs, the PCPs, and patients for their feedback on this process. We heard a lot of benefits. Individuals felt that the best practice alert and the video was perceived to be useful and perhaps helped in providing quality care to the patients, ensuring they were getting the preventive services needed. In general, it was perceived to be relatively easy to use. And the patients reported enjoying receiving this information, which they perceived to be both engaging and easy to understand, and they liked that they got that information right there at the point of care. If they had questions, they could ask a physician right away. The physicians actually, almost 2/3 of them perceived that the intervention may actually improve patient safety as well. Of course, there were many challenges. Electronic health record security and what we needed to do for data collection led to a number of what we call decision points for the best practice alerts, which I'm going to get into more in depth, a bit more in just a moment. Software. An electronic health record system, if there's a software or a system upgrade, you need to make sure that whatever algorithm you've created continues to run and works with the upgrade. We had some hardware challenges with the computers in the exam room. When we first went to start, we realized that not every single one of them had a speaker, even though they had sound capability. And sometimes the speakers would be turned off. And also, sometimes people had changed the monitor resolution because they wanted to see things in larger fonts on the screen, but that actually then made the video look odd. Also, there was no quality improvement strategy for the nursing staff. This was something that they were involved in from the beginning. We worked with them, we trained them, but there was no specific strategy that was identified in the clinic or system-wide. And in the end, this best practice alert really wasn't ideal for the current workflow. And it led back to this issue of electronic health record security and data collection. So to let you know kind of what happened. When we started, we had this idea that maybe it would take 2 or 3 mouse clicks to make this happen. I was imagining when I'm working in a Word document and I go to exit it, if I haven't saved it, I get this very helpful little window that says, would you like to save? And I can hit yes or no. It saves it and it closes. So the thought was we would have this pop up at the end of their electronic health record encounter with the patient, and it would be 1 or 2, maybe 3 mouse clicks. What we learned is, of course, no one nurse or MA necessarily goes through the electronic health record in exactly the same order. Maybe you're jumping from medications to the history of present illness or to other preventive health care, and you could actually close the electronic health record from a multitude of different locations. So to program it to pop up at the end was impossible. What that means is this pop-up had to happen as soon as they opened the electronic health record. As I already noted, we wanted the nurses to have autonomy, so the first click is they had to say, I intend to play the video, or the video is inappropriate. Then they had to accept that decision. Now, part of that was research related. That was so we could actually document and log what did they click. If they had said, I intend to play the video, they had to go in the upper right-hand corner to the toolbar and click on a box that said PNVX video. That then opened an Internet Explorer window. The reason it opened an Internet Explorer is, recall I mentioned the idea was to have the nurse or MA start the video and leave the room. We could not have the EHR remaining open. Certainly that is a large security and privacy issue. So we had to have the video open in Internet Explorer. But the nurse isn't done with the patient yet. So now the nurse has to go back to Epic, finish the encounter, do whatever is necessary in the electronic health record, log out of the electronic health record, go back to the Internet Explorer window, and hit play. 8 mouse clicks. I will admit that when it came down to this, I was a little discouraged because I knew that that was going to be an issue, but we said, let's see what happens. What you can see here is each of these letters is a different nurse or medical assistant in our practice. And again, remember, there was no quality improvement or strategy or incentive that was tied to this. Really, the nurses and MAs were doing this for patient care, to help us out, or for whatever it was that motivated them. If you look at nurses A and C, you can see that sometimes they showed the video, but in general, they said the video was inappropriate. And they saw a lot of the patients. Whereas if you look at nurse E, here was someone who obviously was invested in the project, was keeping it going, and appeared to really try to show the video whenever possible. What I want to point out about this too is just to underscore, 8 mouse clicks is a lot, and that is disruptive to the workflow. So what we're seeing here is understandable. So what did we learn? We learned that there were some surmountable technical challenges, the issues of sound on the monitors, making sure the resolution was accurate, but our primary obstacles really led to there were too many decision points in this best practice alert. It was hard to integrate it into the nurse workflow, and there was an absence of a clinic-wide incentive that encouraged nurse participation. And this did take them more time. So this was originally the end of the project, but we had the opportunity to keep going, and we said, so what's next? We could take multiple strategies. One, we could consider more of a quality improvement policy for nurses, or as we chose, because my focus all along has really been on the patient education and getting the information to the patients, we said, well, what if we try a different channel? We have a video that we think works, that we think is good. It's not working great when we do it in the clinic. What if we use the patient portal that's linked to our electronic health record? And so that's exactly what we did. We thought that patient portals would have the opportunity to provide an alternate channel where we could deliver timely and relevant patient information. So now our objective moved from point of care to actually conducting a single site feasibility study to, again, send patients who are newly eligible, so 65 or 66 years old, for the pneumococcal vaccination, a patient education video through our patient portal, which in our case is MyChart, because our electronic health record is EPIC. And this was sent to them prior to a scheduled visit. So it was linked to an upcoming visit. It was not just a blast that was sent to everyone who is eligible. It would be sent if you had a scheduled upcoming visit. And this is specifically how it worked. If you were registered in the patient portal, and note, we know that not all of our patients are patient portal users. We knew that we were going to be losing a segment of our population here, but we wanted to see, could this be a potential channel? So if there were registered patient portal users, 65, 66, had an upcoming clinic visit, and again, there was no documentation of receipt or refusal of pneumococcal vaccination. So every night in the electronic health record, our code ran to identify eligible patients, and it triggered an automatic message delivery via MyChart. It looked something like this. Now that said, the way that a patient gets a message in our system is you actually get an email in your email that says, you have a message. Then you have to log in, find the message, open the message. If you did open the message, this is what you saw. A general pneumococcal vaccination was the topic. It was addressed specifically to the patient. And of note, it was from their primary care physician. So we had worked with the PCPs. We had gotten their consent to do this. It wasn't a blanket email that was sent out. It was from their own physician. It referenced a medical review of their record and the fact that there was no evidence that this patient had received pneumococcal vaccination. It noted, if you've already got it, let me know so I can update the record. We also noted the fact that there were 2 different pneumonia shots. And I mentioned this a little earlier. When we started this study, there was only 1 pneumonia shot for adults 65 and older. It was the PPSV23 or Pneumovax. As we engaged in this study, the second recommended pneumonia shot, PCV13 or Prevnar, came into play. We didn't want to put that in the video. That starts to get a little confusing. There's a timing aspect. which one should you have first, how long do you have to wait until you get the second one, we felt that was better information that was discussed with the physician and the patient. So we referenced here that there were 2 pneumococcal vaccinations, but didn't get into detail. We didn't want to give too much information. And then the message ends saying, I'd like you to watch a 2-minute video. There was a hyperlink for patients to click. If they clicked, then the video, the same one that you saw, came up and they were able to watch it. So this MyChart message was sent to patients 7 days before their scheduled clinic visit. Patients could reply directly to the message, so they could say, yes, I've been vaccinated, or great, I'll get it, or oh, I really want to talk to you about it. Or if they didn't click the hyperlink or they didn't reply, they were sent a reminder message 4 days later. Since this was a feasibility study, our primary outcomes were actually the message status, was it read or not? The video status, did they watch the video or not? And then of course we were interested in pneumococcal vaccination status, were they vaccinated or not? But that was a secondary outcome. Now here's what it looked like when we ran this study. During the time frame when we ran the study, there were 884 patients who were 65 or 66 years old. Now, about a third of those weren't registered in MyChart. As I said, going in, we knew that we would not be getting the entire population, but a portion of it. We then saw that well over a third of these individuals already had receipt or refusal of pneumococcal vaccine, so they were not sent the message. The other ineligible criteria included cognitive deficits, and since at this point the video was not closed captioned or anything, if there were diagnoses of deafness or blindness, individuals were excluded. And then scheduling issues, sometimes they canceled their appointment, they didn't come, they had to reschedule. So in the end, 116 patients were sent this message. The first time around, about 3/4 opened the message, but as you'll see, only less than 1/5 clicked the video. So we had people opening the message, but not necessarily going to the next step. We sent the reminder message. Again, a majority of the individuals opened the message, and we saw a few more people actually clicking the video link. When we did look at vaccination status, we saw that patients who viewed the video were almost 3 times more likely to receive the vaccine than those who did not watch the video. I want to note here, however, this is a pilot feasibility study. Patients were not randomized to see the video or not. So we are well aware that it's possible that those patients who are already predisposed to getting the vaccine might have been more likely to click and watch the video. Perhaps we reinforced the decision they had already made. That said, reinforcement is also good, but what we can't tell from this study is, did the video really make that difference? So what are some of the implications? After implementation of this patient portal delivered message, it requires really no clinical staff time to deliver the message. And I say clinical staff because, of course, there is information technology staff behind the scenes that are going to need to make sure things are still working with software upgrades, etc. We know whether or not the message was delivered and what the patient response was. We saw that the majority of patients did open the message within a week, and those who viewed the video were more likely to be vaccinated. Challenges and limitations, though, as I mentioned, there was no randomization. There's likely bias happening. In the end, only only a third of them viewed the video. We know we didn't reach those individuals who aren't on our patient portal or maybe have difficulty navigating the system. And we have to ensure that the algorithm stays up to date with our electronic health record. And then finally, as I mentioned, there's what I call the changing face of immunization. We now kind of have this second level or second layer of the fact that there are two vaccines. That said, as I noted, I probably wouldn't put that type of information in such a brief message. So in conclusion, I took you through multiple years, multiple stages of a large project. And what we know is we need to explore varying delivery channels to reach a broader population. We know we need a randomized trial to eliminate bias to really understand how much of an effect the video might be having in the intervention itself. But we do see that using the patient portal is potentially an innovative new channel, and using it prior to a scheduled clinic visit might actually be a feasible method for getting the right message to the right patient at the right time. So a patient who's eligible for vaccination, who's about to go into a clinic visit, and have the opportunity to act on a behavioral intention to be vaccinated, getting the right message to the right patient at the right time. So we're excited. I do want to acknowledge the larger team. As I said, of course, there were a lot of individuals who made this happen. And I am happy to now listen to and take all those questions. Thank you so much for your time today. And again, thanks to NIH and OBSSR for allowing me this opportunity. I know some of you out there, I may know others, as I mentioned, probably haven't met yet. I will be at the Kentucky Conference in Health Communication in mid-April if there's anyone out there who's interested and would like to talk some more. If not, of course, here's my contact information, and I'm happy to answer questions via email as well. Thank you so much.
Terrific, and thank you, Dr. Cameron. It was an informative and engaging presentation. So we're going to begin the Q&A session. I just want to remind you that to ask a question or send us a comment, click Q&A on your screen, select Ask All Panelists, and type in your question and hit send. And I'll turn it over to Dr. Bill Elwood, who will facilitate the Q&A session.
Thank you, Dr. Hunter, and you, Dr. Cameron. We do have a question about actually like measuring the video. Were you able to, did your analytics allow you to determine whether viewers saw the video in its entirety or perhaps even repeated the dosing?
So we did look specifically at whether or not they saw it in its entirety or if they just started the video. We didn't look in terms of repeated dosing of the video. Most of those who started the video did tend to play through, although of course there were some who started watching it and turned it off immediately.
Oh. Go ahead.
So this is Christine again. I do have a question. I thought that the initial data about patient viewing and then likelihood of getting the vaccination was really compelling, but I kept harkening back to kind of your first slides about the disparities and wondered when you were thinking about who's on patient portal and then who are those people that were willing to open and view? Did you notice any kind of disparities that might be, where we might be missing those that are most in need and thoughts about next steps?
Yeah, that is a very critical point. And indeed, on our patient portal, as well as many patient portals, we do see disparities in terms of who is using the portal. So it is possible and likely that we are missing a good portion of our target population. That's actually why we started in the beginning in the clinic, because we thought there we would have a better chance of, getting all the patients who are coming in. Because there were kind of smaller numbers in the end in terms of who actually watched the video and whether or not they got vaccinated, I don't think we can really speak with a lot of confidence to whether or not we saw disparities when we did it through the patient portal. We did have enough participants we did it at the point of care, that we were able to identify that there weren't any racial differences in terms of receipt of vaccine of those patients who saw the video in clinic. But I think you bring up an excellent point, and that is kind of why I was stressing the new going into the patient portal, that we were not reaching our entire population. And so part of it was, here is a next step, but certainly not the only next step. Other next steps then, you know, you can start to think about, well, how can we do better outreach to patients who aren't on the portal? And this project certainly wasn't set up to look at the next thing I'm going to say, but we are very interested in, well, what about all those patients who aren't coming in for care? And that gets to the giving them the right information to the right patient at the right time. Patients are patients regardless of if they're in our clinics or in the community. And really, I think we need to do a better job of saying, how can we get some of this information better out into the community?
Speaking of that, did you get feedback from the patients who watched the video because they got messages through the patient portal? I know you did. We know you did the work on the video itself to refine the video. You mean in terms of those patients? Those, we did interview 20 patients who had seen the video via the patient portal. And really, we got information suggesting that, you know, they thought it was important. Reasons that they gave for not opening the message, for the small number that we talked to, included they just didn't think they had time. As I mentioned, they get an email, then they have to log into the system, see the message, watch the video. Some said, well, I know I'm going to be coming to my doctor within a week, so anything that's there I can just talk about when I get there. And others said, well, I've already gotten the vaccine, which is why we have that reply function too, that they were able to say, I've been vaccinated, especially since we know now that, and encourage, you know, a physician's office is not the only place to get vaccinated. So part of the question is the documentation in the electronic health record accurate? But in general, reasons for not watching the video seem to be time, effort to actually get to the video to watch it, and then this perception of, hey, I'm about to go in, anything I need to talk about, I can talk about within a week. Got you. This next question may be hinting a little too much on proprietary thoughts, but you know, it's been a couple of years since you did this study, and the digital divide. You know, as patients are people are aging into this cohort, they're aging in with increased web and or smartphone capability. Mm-hmm. Do you have seen the implications of that for the future, or is that just not a good question to ask right now? I got another one. Okay, then I'll probably be brief in my answer. That's a fine question to ask, and I do think, in fact, that kind of refers back to Christine's comment about what about reaching those people that you didn't reach through the patient portal. Is there a way that we can look to develop an app or something else that kind of gets away from some of this data security that might be easier for people to access such a video? We haven't done that yet. Certainly, I think that's a great opportunity. And as you noted, you know, we're knowing that as individuals age, more and more have increased technological skills, and we're seeing more and more smartphones out there, and I think that's a great opportunity. Terrific. It's a great question. Remember when you showed us nurses A through T? Yes. And did you get any qualitative feedback from either like I think it was nurse E, who was really dedicated to sharing the the video with patients versus Nurse A or others who clicked video inappropriate so often? Did they give you any feedback as to whether they were the implementers or the video inappropriate clickers?
So we did get feedback, but the way that we structured it was that Nurse A through T, I honestly have no idea who A through T is, and I wanted that to be the case.
Oh, sure.
Yeah. We interviewed nurses after the fact as well when we asked them about their feedback, so we can't directly match them to this was likely Nurse A or Nurse E. In general, a lot of them, you know, I believe the ones that were more likely to click video inappropriate and just make things go away, perhaps they tried it at the beginning. If you recall, there were small green lines there, but they also saw a lot of the patients, which meant they were getting these alerts more often, multiple times a day, perhaps more so than some of the other nurses who did play the video more often. So recognizing that it was a little bit of a glitch in their workflow and it was happening more often, we think that might be one of the reasons for those who were less likely to show the video. Then we did have some nurses that really kind of talked about how important this type of intervention was for them and how they then felt part of really providing the preventive service, increasing, you know, patient quality and safety. And I think a lot of that was more of an internal motivation of saying, I believe patients should be getting the pneumococcal vaccine, and if I can do something to help, I'm going to do it. Those are the types of things we heard, which may explain, you know, some of the Nurse A through T that we saw.
Okay, that was a really thorough answer. Thank you.
We actually did ask.
It was a great answer. So I guess we want to close this up, but first we want to say thank you so much to Dr. Cameron for an engaging presentation and to all of you that logged into the webinar. We appreciate your joining us. There will be a recording of today's webinar. It will be available in about a month. And our next webinar will be on Tuesday, May 15th, and our guest speaker will be Dr. Linda Larkey, a professor in the College of Nursing and Health Innovation at Arizona State University. And with that, that concludes today's webinar, and we hope all of you have a wonderful rest of the day. And thanks again, Dr. Cameron.
Thank you so much for the opportunity. And thank you all for listening.
Certainly. Goodbye, Dr. Cameron.
Bye.